thank you for the kind introduction. So I really picked minimal residual disease. It's quite a hot topic right now in the scientific myeloma community. We test it on almost every patient, but I feel like a lot of patients don't really know what it is when we tell them in clinic, what their MRD level is. So I thought I'd introduce it to you as patients or friends, relatives of patients also. So preparing this talk, I realized to understand really what MRD or minimal residual disease is, you have to know what myeloma, or you have to know a little bit about myeloma, how it evolves, what the diagnosis is, and what other response criteria are to multiple myeloma. And then you can eventually also discuss how minimal residual disease plays into all of it and into response criteria. So I'll have some short introductory slides at the beginning. Essentially, you probably know that already, but myeloma is a cancer of plasma cells. Plasma cells that have become malignant, and it's a bone marrow cancer. It's the most common bone marrow cancer, in fact. Bone marrow is the spongy tissue inside the bones, it can involve bone damage when the myeloma starts to grow within the bone marrow, but it is not really a bone cancer. So a lot of patients think it's a bone cancer, but it's not. It's a bone marrow cancer. Its incidence is approximately 30,000 patients a year, which compared to other cancers, lung, breast, it's really not a lot. It's probably around 1% of all cancers, but it's the second most common hematologic cancer, and again the most common bone marrow cancer. It's more prevalent in patients of the age 60 and up, though we do see also an increasing incidence in younger patients. We've seen that it's more common in males compared to females, and it's more common in African Americans compared to other ethnicities, and we don't really know why. There have been some agents that have been associated with the development of multiple myeloma, in particular Agent Orange, ionizing radiation, and the existence of immune disorders. These patients or people who have been exposed to these agents have minimal high risk to develop multiple myeloma, but you can see, or you can you can see that that only a few patients really have been exposed to such agents. So really, for most patients, it remains unknown why myeloma developed in them. So how do you diagnose multiple myeloma, or what are the clinical criteria of multiple myeloma? Really, there are mainly four organs or four clinical pictures that come into play. The first one is abnormality in blood counts, which at least 60 to 70% of patients have, with mostly a low red cell blood count, anemia. Half of the patients present with some sort of renal failure. Some patients present with a high content of calcium in their blood, which leads to clinical symptoms like confusion or renal failure, and then the vast majority also have bone lesions. Now, all these criteria have a letter for abbreviation, and if you put it together, there is an acronym called CRAB. And typically, any myeloma patient will present with any of these criteria. So this is a diagnostic criteria. If anybody comes to their primary care physician with one of these criteria, myeloma should be definitely ruled out. And again, patients develop these clinical symptoms because they have a bone marrow disease, multiple myeloma. And as you can see here, I know it's maybe a little bit far-fetched for you to to look at pathological pictures, but essentially that's what the pathologist is looking at. Bone marrow full of myeloma cells, and you maybe can see that all these cells are equal, are the same. So they're expanding, they're taking over, and they're kind of suppressing all other cells that are producing blood, and that's why your counts, or that's why the counts in multiple myeloma patients are typically suppressed. Now, again, myeloma is a cancer of plasma cells. So every person has healthy plasma cells, and then for some reason, some genetic reasons mostly, the cell becomes abnormal, becomes a myeloma cell, and then this myeloma cell has propensity to grow and take over the bone marrow. So every healthy plasma cell and myeloma cell has antibodies on their surface. In healthy plasma cells, they help to fight infections. In myeloma cells, they really are not functional, but they're still being produced. And this is typically the protein we talk of when we say, okay, multiple myeloma produces proteins that goes into the blood and then can clog the kidneys or cause other symptoms. So that's what we mean when we talk of this protein. And you probably have heard of it. The antibodies consists of two parts. One is the heavy chain, that's usually IgG, IgA, IgM, and then have a light chain, kappa or lambda. And each myeloma patient will have one or the other type of protein, or a combination. So most common is IgG kappa, but it can be IgA lambda, it can be IgG lambda, so various combinations. It has nothing to do with being a bad myeloma or a good myeloma. It just means it's a type of myeloma. So if the patient has a lot of myeloma cells, obviously a lot of protein is being produced and is going into the blood, and then we check the blood for. We do a test called serum protein electrophoresis, or SPEP, and we can see that, or this test serves mainly to see what protein is in the blood. I mean, there are various types of proteins. That is not the only protein. We have good proteins, which is albumin, and then other types of proteins, but you can see in a myeloma patient, the antibody protein is really high compared to patients that don't have myeloma, where we just have few amount of antibodies. And this then is called the M protein, the monoclonal protein. That is being followed through a treatment. And ideally, when you have a patient that is being diagnosed, you treat it, and this M protein is going down over a certain time frame. So that kind of leads us then into the response criteria of multiple myeloma. Obviously, when you treat myeloma, you want to get rid of the actual disease in the bone marrow. And the markers like the M protein or the IgG, IgA, and kappa or lambda light chains are reflection of the tumor burden. So one criteria of a remission is essentially that the M protein should go down to 0. And that, ideally happens within the first 6 to 12 months of treatment. Other criteria that then complete the definition of a complete response are a bone marrow clearance of multiple myeloma. So again, you have here a picture with multiple myeloma cells. You can see they're all the same. Essentially, when these are being treated, it gives you a normal looking bone marrow with different cell types that again are able to produce blood. And so typically your counts, or the patient's blood counts, increase during treatment. Another criteria of a complete response is the resolution of lesions. We've briefly mentioned at the very beginning that bone lesions are found very frequently. 70 to 80% of patients present with some sort of bone lesion. This is a PET, where active lesions can be identified, and ideally with treatment, all these lesions disappear. So again, if you have all three, you have no evident blood markers, a clear bone marrow, and no lesions, then you fulfill the criteria of a complete remission. Now, you have to see that when the pathologist looks at this, you might think, or you might even realize now, that there might be some myeloma cells hiding, which he or she just doesn't see. So what we've seen over time now is that achievement of a complete remission really can just mean that the tip of the iceberg has been treated, and there still can be a lot of tumor burden that was just not been able to identify with methods we had in the past. So complete remission, again, is a term that has existed over the last decades, and it was as good as it could get, but really we know that even with the achievement of a complete remission, a lot of tumor burden could still exist. So if a patient was in a complete remission, we just didn't know, did he have that much left or this much? So showing the same picture just in another graph, really getting to complete response could mean you still had a lot of treatment, a lot of tumor burden left. And obviously that reflected, and also that was reflected in treatments. Getting somebody into remission could mean that they also relapse pretty quickly if a lot of tumor burden was left. So the paradigm of this institute here was always to treat very aggressively, to actually eradicate everything which was left, even that we just didn't see in patients who achieved complete remission. Because the theory obviously is that only if you eradicate everything, you potentially will be able to achieve a long-term remission where the disease just does not come back. And this is exactly where minimal residual disease measurement comes into play, because with now the newer techniques that just that have now emerged over the last 5, 6, 7 years, you are able to see what's beneath the tip of the iceberg. So minimal residual disease is essentially detecting myeloma cells on a much more sensitive level in the bone marrow. The test is being done on bone marrow samples. It's not on blood samples or anything else yet. Maybe in the future we will have that option. And again, we have currently 2 methods to test for minimal residual disease that I will go into a little bit more in detail now. So one test we do in-house here at UMS is called flow cytometry. Again, when we have a healthy plasma cell here that through some mechanisms becomes the myeloma cells, and we've seen that there is a difference in antibodies, but there's also a difference in a lot of other surface proteins. So as you can see, both cell types express CD38. It's a very typical marker for myeloma and plasma cells. But then other markers are expressed on healthy plasma cells, but not on myeloma cells. And then CD56 in this example is being expressed on myeloma cells, but not in healthy plasma cells. So knowing that, we have a very elegant method with flow cytometry that is able to detect surface markers, and then by doing so is able to detect plasma or myeloma cells on bone marrow biopsies where we otherwise would have thought they're in complete remission. So just looking at a flow cytometry template, to make it easy, the red cells are myeloma cells, healthy plasma cells are blue. Lymphocytes are just used for control, but if you focus on the blue and the red cells, you can see that, again, by expression of these surface markers, you can distinguish between healthy plasma cells and abnormal myeloma cells. And the machine test, I call it always in clinic, but this flow cytometry is able to tell you, wait, your patient is in remission but still has some myeloma cells left. This particular test, flow cytometry, has a sensitivity limit. So every test, machine test also, no matter if this or the next one we'll discuss, has a threshold. The flow cytometry can detect 1 in 100,000 cells, which is pretty sensitive, I believe. I mean, if you look at the pathologist will never be able to see just one myeloma cells in a mixture of 100,000 cells. So if you then calculate that into percentages, 1 in 100,000 cells will give you, it's sensitive to 0.001%. So that's what we typically tell the patient. We dictate this in the notes. I just don't know if patients know what that means, essentially. So that's why we're giving this lecture also today. Again, this test is performed in-house, meaning at UMS, so we'll have the result whenever you see the oncologist also at your visit. Now, there is a second test, which we use sometimes, but it's not being done here. It's a sent-out test. It goes to a company called Adaptive Biotechnologies. Can Google that company. There's a lot of literature out there on this company. It's probably the main company that does MRD testing in the United States. Good thing is it really is more sensitive than flow. It goes 1 log deeper, so it detects 1 in a million myeloma cells. So technically, patients who are negative here could still have some cells detected by this more sensitive method. And we'll see in a moment what that means. I mean, it's a really low level of infiltration, but I will show you why we actually do that or why we think that is important. Just a few words, a few slides on this other method. It's essentially a very different approach, a different technique that requires a baseline sample, and I'll show you why. Again, this test goes back to the antibody we have on the myeloma cell. Now, the adaptive biotechnology approach is such that it traces the DNA of the myeloma cells that is responsible for producing the antibody. So it will, at the very beginning, when you have really a lot of myeloma cells, it will look at the certain DNA sequence of the myeloma cell. And this is a unique sequence of the DNA. It's a code that uses 4 letters, as you might know. And the particular sequence is identified in the initial sample and is then being traced in the follow-up samples. And the reason we need a baseline sample essentially is otherwise the specific test would never know which one is the normal healthy plasma cell sequence and which one is the myeloma sequence. So we sometimes have a little bit of issues with patients that come referred, are pre-treated, don't have really a sample available here from their diagnoses that we can send off. So these patients, sometimes it's difficult for these patients to do their test from our institution. If you do that test, the company really gives you a nice sheet to look at your MRD load over time. In this particular example, this patient achieved MRD negativity over a time frame of 3 years. So as you can see, it's not like achieving a complete response in 6 to 12 months. It really takes longer to achieve MRD negativity, which probably makes sense because it takes longer to eradicate all the remaining tumor burden. Now, why is it that we do these tests? And obviously, there's a lot of literature out there saying that patients that achieve MRD negativity will do better because they don't relapse, obviously, that quickly. So it's not that easy. There's a lot of it to it. So in particular, in this study, patients were tested. Only patients that achieved a complete remission were tested, but they were also tested at the very end of maintenance. So test and then maintenance was held, and then we'll see what happens. And obviously, patients that were MRD negative, you can see here with every drop in the curve, it means a patient relapsed. Patients that were positive, there were more that relapsed than patients that were negative, which makes sense because they had still some tumor burden on board. you can see that patients that are MRD negative still can relapse over time. So there must still be some tumor burden that we just don't see, even with those sensitive methods, that over time can come back. However, even here, the goal of each treatment is such that we try to get a patient into MRD negativity, because over time we see that those patients don't relapse, or have overall better outcomes with lesser relapses. Again, it becomes more complex if you look at, well, is the patient a low-risk patient or high-risk patient? Now, I haven't really touched upon high-risk, low-risk. It's also quite a complex topic, but you should know or discuss with your oncologist if you're low-risk or if you're high-risk. That is usually determined at diagnosis. So what we've seen is that patients who have low-risk disease, but this is our data from our institution here, and we tested MRD levels 8 months into treatment, which typically means if you're treated aggressively after your stem cell transplant. And then we tested MRD levels after 24 months of treatment initiation, so that's typically when you're in maintenance. And we've seen that, some patients after 8 months are still positive, some are negative, but at that point in time, but it really doesn't matter, so it has no implications on their outcome, because they're still being treated, and with with ongoing maintenance, a lot of patients achieve MRD negativity.
It's a 2-year maintenance. It's a 2-year maintenance program.
No, it's a 3-year, but this is measured after 2 months, after 24 months. So it's true that the remaining time of maintenance is probably short. That's why a lot of patients who are still MRD positive here will likely relapse. However, it also means that if you haven't achieved MRD negativity after 24 months with the current maintenance, you're unlikely. You might want to change about it. You might want to think about a change in treatment at that time point. Because after 24 months of ongoing treatment and maintenance, if you're not changing your regimen at that time point, you're unlikely going to achieve MRD negativity. So again, in low-risk disease, we think the time to achieve MRD negativity can be, even can be a little bit longer. Can be after 12 to 24 months, but we still think that achieving MRD negativity is the goal in this population group. Now, high-risk patients are different. Again, high-risk patients typically present 15, maybe 20% of the whole myeloma population. High risk really means, the disease is more aggressive, and that's reflected by typically relapse. These patients relapse much sooner. So we tested here also high-risk patients that have an aggressive approach with stem cell transplantation. Are they MRD negative after 8 months or not? And here you can see those that are negative have a significant better outcome, or relapse less frequently than those that have MRD positivity. But surprisingly, even those that are MRD negative still have a high relapse rate, and that really remains the clue and the issue with high-risk disease, that the disease relapses quickly despite aggressive approaches. So it's not uncommon for high-risk patients to have MRD negative disease and then relapse with a lesion or lesions, but still being MRD negative. So there is this discrepancy, which is likely explained by different clones at different sides of the skeleton, it's kind of that's where the difficulty in treating high-risk disease remains. But as you can see, in high-risk disease we really try to be even more aggressive upfront to bring patients into remission and MRD negativity, because if you don't, if you still remain with minimal residual disease in high-risk disease after stem cell transplant or early on into maintenance, then it becomes difficult and you have a high likelihood of relapse. After 24 months, again, most patients here, there was only one patient who was MRD positive who relapsed quickly. Most patients, even here that are MRD positive, have a risk of relapsing throughout the time course, but definitely being MRD negative will, there are some that will have good long-term outcomes. So MRD negativity in these patients remains the goal. Overall, it remains the goal, but even more so in high-risk disease. So, with that, I kind of covered a little bit the basics in terms of diagnoses, the methods, and the prognostic implications of MRD assessment. And I want to thank you for participating, listening, and I'm happy to answer any questions. If anybody has questions.
What's the length of your test results now? Is 8 years? Is how far you've done your study so far?
Yeah. So, yes, in this particular study, we used stored samples. So we started using MRD testing in early 2014 with the flow. So we have 5-year follow-ups with the flow. In this particular study, we used stored samples that we sent to this company, Adaptive, and we had the outcome, and then could look based on MRD testing, how did patients do. But for the flow data, actively doing MRD testing, it's 5 years. So we're still gathering data with that also.
For 5 years. Mm-hmm. So you went back and gathered data from previous bone marrow biopsies from other people that you hadn't stored, is that correct?
Yeah, so the flow cytometry, that in-house test, we cannot do on stored samples. It needs to be a fresh sample.
Okay.
So
you sent the frozen samples to the other company?
To the other company, correct. But this was, it's kind of a research project because they, as a company, you cannot obviously clinically reimbursed for testing on stored samples. So it was it was a rather small study, but it was all the stored samples we had, where we had consecutive or sequential samples available.
And what was your sample number?
So in this study, for low risk, it was approximately 30, 50, 80 patients, and for high risk it was 30 patients. So overall 100, 120, so not a lot. But there is a lot of literature on MRD testing now out there. Obviously none of them have really looked so much into differences of low risk and high risk disease. I think we were the first ones to publish on that. And overall, survival curves still differ a little bit what treatment you use also. So the relapse rate might be different from one center to another.
Depending on whether do stem cell transplants or what other drugs you're using or whatever.
Correct. Correct.
Does your data seem to mirror other people's data though?
I think the data consistently has shown that achievement of MRD negativity is definitely a treatment goal. Questions remain, obviously questions that are we're trying to answer is, okay, if a patient achieved MRD negativity, does that mean you can stop treatment? Probably not, but how long does he need to be MRD negative to kind of be safe, or say on the safe side to stop treatment? Yeah, so there's never a guarantee, and you cannot treat indefinitely, right? You cannot just use maintenance for 20 years and say, okay, we'll try to prevent relapse, but we cause a lot of side effects otherwise. So there is data now that, if patients remain 2 years MRD negative, that certainly is a good marker, and that at that time point, you definitely could think about holding maintenance if the treatment protocol also anyway would suggest to stop maintenance. But these are questions that really remain, how to guide your treatment around MRD testing. We certainly, we've gone through, we've come to that point where, when we see reactivation. So when a patient relapses, MRD is typically one of the first things that will come up as a reflection of disease burden. And we've come to the point where we will actually change treatment regimen based on MRD testing, even if everything else looks good, So patients are still in a complete remission, have negative markers. The bone marrow morphologically to the pathologist looks negative, and there's no lesion. We are kind of considering to be, more upfront, more proactive, and treating MRD reactivation rather than waiting for a, clinical relapse, which, historically was defined by increase in bone marrow cells, increase in markers, or detection of a lesion. So we're not waiting that long anymore. So we've become definitely more proactive in counteracting relapses when we see MRD is trending up. Yeah.
I
want to know, once it gets a relapse, that means it's getting good, or it's gonna come back.
Yeah, relapse means it.
When I was taking Ritalin, now they got me on another different type of medicine after it flapped up in December.
Mm-hmm.
So now all of a sudden it's doing good. But I still take it at home as well. And then he still had me try it out. And I've been taking bone marrow. It's like they ain't never collected no cells. So once in November, I could see my doctor again. I had to do bone marrow again. This will be my 4th time.
Mm-hmm.
But he wanted to do the cell transplant. How you gonna do the cell transplant and the bone marrow still coming?
If the bone marrow is what?
If the bone marrow, if I got still do bone marrow and they never collect no cells.
You wanted to know how you can get a bone marrow transplant if his blood's infected, I think, essentially.
If they collect no cells.
Since I've been here, they ain't collect no cells. They couldn't get it, so I've been telling them to use an 8-inch needle. But they say they're gonna do it next time.
Yeah, I wonder, so if you say collect no cells. Okay. So you have not collected stem cells yet?
No.
Okay. And when you're saying they don't get no cells from the bone marrow, is that no myeloma cells?
Yes. And I was trying to know how long they stay in relapse.
Yeah, so the myeloma? Mm-hmm. I mean, the stem cell collection is not it does not depend on the myeloma burden in the bone marrow. You can collect stem cells anytime, ideally with growth factors. That is independent of the MRD testing of the myeloma cells in the bone marrow. Ideally, collection is done at the beginning of the treatment because the more treatment you get, the stem cells become affected by the treatment, and it becomes more difficult to collect.
So after this, I just heard you go chemotherapy once a month. What happened after that next? You could still be taking your medicine at home after that chemotherapy over with?
Yeah. So the the exact treatment plan is always best, if you discuss that with your oncologist. But typically, yeah, if we do, I think if you get a stem cell transplant, then yes, you usually do still pills and injections at home. Yeah.
So when I'm looking on my chart, and I'm looking for the flow cytometry, I'm looking for IFE group, is that correct?
No, IFE is the immune fixation.
Okay.
That is, so that is a test similar to what I showed with the M protein. It's a similar blood test.
So it'll say flow cytometry?
It should say MRD flow cytometry, yes.
Okay. I just want to know what to look for.
Is it, I think, I'm not so familiar with my chart, to be honest, but it should be on there because I know a lot of patients know their
It
results.
is, I just didn't know which one to look for sure.
Okay.
I'm looking through it now, I'll tell you if I find it.
Yeah, and it will give you then a percentage. So undetectable is less than 0.001%, or if it's positive, it will give you a certain.
That's right, it's done on bone marrow when you're back biopsy,
Yeah.
right? It's not done on blood, and the IFE group is done on blood.
Correct.
Okay.
Correct. Okay, I hope everything is clear or not, I don't know, but yeah, if no questions otherwise, then thank you very much for your attention.